What a difference a year makes. Football fans follow the European Championships, in some places even without masks. Bands are playing before live audiences. And people are traveling again. But is all of that a good idea? Just over a year ago, the coronavirus made the world shut down, brought death and despair.
I'm seeing young patients, old patients, people of all age ranges who are just incredibly sick. And you can even hear it now, that as I'm walking through patient rooms in the hallway, you just hear oxygen.
Now there are vaccines in countries where many people have had them. More than half the population in the worst hit country, the US. In Britain, that's even 2/3. After more than a year of COVID-19, we've become familiar with complex medical terminology, difficult virological concepts. But we also realize it's not going away that easily. Britain and the United States are having trouble convincing more people to get vaccinated. The new Delta variant is spreading rapidly. And vast regions like Africa still lack vaccines. Is it really time to celebrate? Welcome to your COVID-19 special. I'm Chris Colbert in Berlin. Life is beginning to return to normal in many places, as the worst of the pandemic looks like it might be behind us. But there are spots in the world where it's a different story, like in Australia, where several cities are reintroducing restrictions to try to contain new COVID-19 clusters, some linked to the Delta variant. Sydney and Darwin have begun new lockdowns, while other cities are reintroducing mask wearing. Only 5% of Australia's population have been fully vaccinated. Now, this shows dealing and living with the virus is still necessary for now. COVID-19 isn't gone. Let's get more on this from Julian Tang. He's a virologist and a clinical microbiology professor at Leicester University in the UK. Welcome to DW, Julian. For more than a year, the coronavirus has determined the daily lives of people around the globe. Now, you've been researching respiratory viruses for years. How is this virus different?
Hello. So this virus is not really behaving much differently from a typical pandemic virus entering a totally susceptible human population. I think what's different about this virus now is the way we can actually study it in real time and also track all the different complications as well as the case numbers, death rates, asymptomatic versus symptomatic transmission and infection, plus also the vaccine developments and the antiviral trials that are being developed for this pandemic.
Now, the coronavirus is not as deadly as Ebola, for example, nor as difficult to combat as HIV. Nevertheless, it has triggered an unprecedented global crisis. How exactly?
So HIV tends to attack a certain group of the population, and Ebola, again, is very geographically confined, whereas the COVID-19 pandemic has really affected everybody from every country, every socioeconomic status individual, and also including the healthcare workers that look after them. So this is a virus that spreads very much more in the vein of influenza than measles, for example, but it also can cause asymptomatic infection and is very transmissible pre-symptomatically, which is different from the previous SARS virus back in 2003, and also different from things like smallpox and Ebola to some extent, because it can actually be transmitted up to 5 days before symptom onset, and some people never develop symptoms at all and can still spread the virus. And now we're seeing a penetration into the younger population in primary schools, secondary schools, where these children mix in classes of 20 to 30 every day, 5 days a week, and bring the virus home to their parents or the other adult carers. And now we're seeing much more of a focus on this younger population who haven't been vaccinated yet.
Now, the younger population being more affected by the coronavirus is one of the things that has many people worried when it comes to the Delta variant. How worried are you about this mutant?
So this has been worrying the reasons. One is that it's actually breaking through the double dose vaccinated individuals in the population. Two, it's come at a time when the vaccination of the older people has been mostly completed, although we're still seeing some breakthrough infections there. But now it's focusing on the younger people, and the younger people are the ones who are still working and driving the economy as well as in full-time education. And also we're seeing an emergence of long COVID in a greater way than previously, because previously it was obscured by deaths and hospitalization cases, but now we're seeing a lot of long COVID emerging. 30 to 50% of people having had COVID can get long COVID, and this may become a chronic healthcare burden on the society.
Julian, when the coronavirus started developing these variants, word among scientists was, well, variants are more contagious, but probably less deadly or less likely to trigger severe cases. Is that still the case when it comes to the Delta variant?
So it's a bit hard to say at the moment, and now we've got Delta Plus with the Delta AY1 carrying the South African 417N mutation. If these variants keep emerging and changing as we try to assess them, it's very hard to actually assign severity in a very definitive way. But one aspect that we haven't really picked up on now, though we did discuss it last year, was this idea of antibody-dependent enhancement. And I was just wondering whether the previous immunity given by vaccine or natural infection to the original Wuhan virus might be reacting in a different way to these newer variants that may actually allow some enhanced severity of illness based on that baseline of immunity induced by the previous Wuhan virus natural immunity or the vaccines which are based on that original virus. That's something that we need to look into.
Now, scientists have learned a lot about the coronavirus in just the course of 1 year and quickly develop effective vaccines as well. What are the things that researchers do not yet know and that they're specifically looking into?
Okay, so there's just some news coming out from the UK about the mixed vaccine regimen, which shows that if you give one dose of the AstraZeneca first and then a second dose of the Pfizer 4 weeks later, you get a very good level of immunity. So this mix and match vaccine seems to work quite well, and even the reverse order seems to be quite effective. So that will help hopefully broaden the vaccine options globally. But of course, there are many other vaccines to try in this. The other thing is whether reinfections or breakthrough infections also have a kind of higher risk or lower risk of long COVID versus just natural infection for the first time. We're not sure what the consequences of that reinfection would be, because a lot of the reinfections are milder, but we don't know whether that actually increases or decreases the risk of long COVID as well.
Julian, in your opinion, have mistakes been made in research that might have contained the extent of the pandemic? Briefly, if you would.
Yeah, so I think all of Europe and North America have realized that they could have acted earlier and more dramatically, like we saw in Southeast Asia and to some extent in Australia and New Zealand, to lock down the virus earlier, to give time for the vaccines to be developed and distributed and administered. So I think countries like Australia, New Zealand, and the Southeast Asian countries have got it right in the first part of the pandemic. But now what we're seeing is an increased degree of vaccine hesitancy and refusal in those same countries that actually did very well to control the virus, because they see the virus as less of a threat than the vaccine adverse effects. And that change in mentality needs to be made to protect everybody from ongoing replication of the virus and the generation of new variants.
Julian Tang of Leicester University, thank you for your thoughts.
Thank you.
And now it is time to put one of your questions to our science correspondent, Derek Williams.
Will COVID-19 variants just grow stronger and stronger over time?
This is a tough question to answer because it assumes that evolution is predictable, which it isn't. Mutation happens randomly in virus genomes as they replicate. And the physical changes that those genetic changes end up causing in the virus is what we mean when we talk about it evolving. A tiny fraction of those mutations, just by sheer dumb luck, they'll provide variants with evolutionary advantages of some kind. A big advantage, as we've seen, for instance, with the alpha and the delta variants of SARS-CoV-2, is if a variant becomes more transmissible for some reason. But transmissibility can increase for a range of reasons. One is, say, that a variant is able to get your cells to to make a lot more of it than your average workaday SARS-CoV-2 virus can. Another would be if a variant were able to remain viable longer in the environment, hence increasing its chances of infecting someone. So very different reasons, same effect. See what I mean about predicting this stuff? So when you say stronger and stronger, which I assume means causing worse and worse disease, then you have to start by asking whether doing so would provide a variant with an evolutionary advantage of some kind. And it's hard to see how it would. A lot of virologists say a more optimal combination of traits for a virus is to grow eventually more transmissible, but at the same time less deadly, because if a pathogen doesn't kill people, they're going to be around to spread it to others, and they're more likely to let down their guard and infect each other with it. So, though we can't predict with any certainty what future SARS-CoV-2 variants will look like, many experts expect them to spread more easily but cause less severe disease. It could well be that within 10 or 20 years, getting COVID-19 won't be any worse for the average person than, say, catching a cold is today. But because evolution isn't predictable, that's just a hopeful guess.